So today's topic is about connectors in FPD. FPD has got three components, that is the pondic, retainers and connectors. So pondic is that part of FPD which replaces the missing tooth, and retainer means the part of the FPD that is going to be cemented onto this abutment tooth, and connector means it is that portion of FPD that unites the retainer and also the pondic. So the connector, there are two connectors which is present in this FPD. So this is also a connector and this is also a connector. So according to GPT 8, the connector is that portion of FPD that unites the retainer and the pondic. So basically we can classify connectors into different types. Basic classification is it is classified into rigid and non-rigid connectors. But based on the connectors, we can classify FPD into fixed, movable, and fixed, removable. So when a question on classification of connectors is asked, you can include this classification also along with the types of connectors. So we can see the classifications in detail. So FPD's connectors is broadly classified into two types, that is a fixed, movable, and fixed, removable. And basically it is classified into rigid as well as non-rigid connectors. In rigid connectors, we have got cast connectors, soldered connectors, loop connectors. In non-rigid connectors, we have got tenon mortise connectors, split pondic connectors, and cross pin and wound connectors. So coming to the first type of connector, that is a fixed. In this case, as the name indicates, there is no scope for any movement. So connector on both sides of the pondic are rigid. So we have got a rigid pondic on both sides, rigid connector on both sides of the pondic, and there is no scope for any movement. So either it is soldered to the pondic or all the components are cast as a single piece. This is how we fabricate a fixed type of connectors, and this is the most commonly seen type of connectors in most of the FPDs. So here you can see a 4-unit FPD. So this is a normal FPD, and you can see a type of fixed connectors in this, which is cast as a single piece. So coming to the next type, that is the fixed movable. So in this case, one connectors of the FPD, it is non-rigid. So that means it allows some vertical movement. So usually we use a precision or semi-precision attachment which allows some vertical movement. And it is called non-rigid connectors because it allows some vertical movement that is between the pondic and this abutment. So it is what is the indication of this type of connectors? So when you plan an FPD for a fire abutment, or when you plan FPD for a tilted abutment or periodontally weak abutment, that means when you in the case of tilted abutment, it is difficult to get a path of placement. So because abutments are not parallel. So in that case, you can use fixed movable type of connectors, that is the precision attachments. And in the case of fire abutment, you can use. And when you want to cut down the stress to particular abutment, that is in the case of a periodontally weak abutment also, you can go for a precision attachment. So this is precision attachment and for managing a fire abutment. So coming to the next type, that is a fixed removable. That means it has got a fixed portion as well as a removable portion. So it was first developed by Dr. James Andrew. So we commonly call this type of FPD as the Andrews bridge. So like shown in the figure A, it has got a fixed portion which consists of two abutment retainers which is adjacent to the edentulous space. So this is an edentulous space, and you can see the two abutment retainers which is adjacent to the edentulous space, and that is joined by a bar, that is printed by a bar, and the retainers are attached to the bar and are cemented onto this abutment. So this is the fixed portion of this FPD. So you can see the two abutment retainers, which is adjacent to the edentulous space, which is printed by the bar. And removable portion means it is made up of acrylic, that is a danger flange with a steel and the artificial teeth which clips onto the bar. So this is an acrylic danger base and an artificial tooth. All these are made up of acrylic. But the only thing is it has got a sleeve within which it is going to be clipped onto this bar. So that is how it is going to be retentive. So what is the main indication for this Andrews bridge is that it is indicated with a patient with an extensive bone loss, especially in the case of a Sibbert's class 3 bone loss, that is both horizontal as well as vertical bone loss. If it is severe, it will be so, highly anesthetic if you plan for a conventional FPD, because that will result in a long pondic with no lip support, especially that will be so anesthetic if the patient is having a high smile line. Also, that will be so anesthetic. So in such cases, if we plan for an Andrews bridge, that will be more aesthetic and also comfortable for the patient. And it is also indicated in the case of a long denture span. So it is better to go for an Andrews bridge if you are planning for a long denture span. So that is better option is fixed removable option. So that is the main advantage we can say with the Andrews bridge is the flexibility in placing the denture teeth, because the patient is having a fixed prosthesis, that is a fixed portion, and also he can remove the denture teeth part. So, and also that will be basic idea is that aesthetics is not compromised. And also this is the only option for a patient with an extensive bone loss. So that is the first classification, that is classification of FPD based on the type of connectors, that is the fixed movable and fixed removable. Coming to the next classification, that is the rigid and non-rigid. So rigid means that do not allow any movement and indicated when entire masticatory load is to be transferred to the abutment. So when the abutment is healthy and abutment is capable of taking up the masticatory load, then we can go for a rigid connections. Either it can be soldered or it is cast as a single piece as a part of FPD. So this is the type of rigid connectors. Example, this type of connection is the rigid connection. And also another type is the loop connector. That is when the patient is having a diastema and patient never wants to close that existing diastema, it is to be maintained. Then another option is the only option is a loop connector. So it is also a cast type of, it is also to be, it is mainly cast, and care should be taken that the tissue contour is followed during fabrication of the wax pattern of the connector. Only thing that the connector is a U-shaped connector, so it has to follow the tissue contour at the time of fabrication of the wax pattern. So coming to the design, the size, shape, and position of the rigid connectors influence the success of the processes. So that means an ideal connector means it should promote adequate cleansing, it should have adequate strength, and it should be aesthetically acceptable. So when you design a connector, the size should be large enough to prevent the fracture or distortion during the function, and too large connector that leads to ineffective plaque control, and that is also anesthetic. So when you plan, size should be large enough, but it should only thing is it should prevent the fracture. It should not be too large. Coming to the tissue surface, it should be curved facial-lingually for the efficient cleaning. So connector should promote adequate strength as well as adequate cleansing. Buccal-lingually, it should be elliptical, and mesiodistally it should be shaped to create a smooth transition from one FPD component to the other, that is similar to the meniscus. An anterior connector should be placed towards the lingual embrasures for the purpose of aesthetics. So when you plan a rigid connector, we have to take into consideration all these factors, that is the size, tissue surface, buccal-lingually, and mesiodistal shape, then anterior connector position. So all these are very, very important for the success of the prosthesis. So coming to the non-rigid connectors, that means it allows limited movements. That means it allows a limited movement between the retainer and the pondic and have a little amount of flexibility. That is why it is called as a non-rigid connectors. So when is the non-rigid connectors indicators? That means when we cannot achieve a parallel path of insertion. That is in the case of a tilted abutment and all, Sometimes it is difficult to achieve a parallel path of insertion. So in such case, we can go for a non-rigid connectors. Next is in the case of a fire abutment. When we suspect a much more closer load onto this intermediate abutment or fire abutment, we can go for it act as a stress breaker. And actually, this is included in the special consideration, which we'll be discussing on the last portion of this class. So that is fire abutment and periodontally unfavorable abutment. When we want to reduce the amount of stress which is transferred to the tooth, then it can act as a stress breaker also. We can give a non-rigid connector in that area. So coming to the types, almost all of them will be having a male as well as the female component. And the shape and configuration of this male and female component will differ to accommodate the movement between the conduit and the retainer required. So always precision attachment or non-rigid connectors always have this male as well as female component. So there are different shapes of different types of precision attachments which is available for non-rigid connectors. So basically, commonly we use three types of non-rigid connectors in FPD. That is the tenon mortise, split pondic, and crosspin and pin. So let us discuss the first connector, that is the tenon mortise connector. So tenon means it is a male component. So you can see here, this is the tenon, which is the male component, and it is attached to the pondic. So this is a 5-unit FPD, and in this case, you can see there are this is the anterior abutment and anterior retainer, and 2 pondics are there, and this is the terminal retainer. So this is actually the pondic means it is attached to the tenon means or the male component. This is attached to the pondic, and mortise or the female component. This is the mortise, and which is a box shaped. So it is attached to the retainer, and their alignment must be parallel to the path of placement. And they can be made, made freehand, or it can be milled or prefabricated plastic patterns can be used at the time of the fabrication. So this is how the tenon mortise connector looks like. So that is, tenon is attached to the pondic and mortise which is attached to the retainer. So coming to the next type of non-rigid connectors, that is the split pondic connectors. That means from the name itself, the pondic is split into mesial as well as distal halves, which are attached to the respective retainer. So you can see here this is a fire abutment situation, and you can see this is the distal pondic, and this distal pondic is split into mesial as well as the distal half. In that, this key is attached to the mesial half, and keyway it is in the distal half. So keyway this is the keyway, and this keyway is attached to the distal half, and key is attached to the mesial half. And this assembly engages, and when the FPD is seated in the position. So this main indication is in the case of a fire abutment situation, and where the minimal amount of movement is required to maintain this abutment head. So we have to cut down the stress which is transferred to the fire abutment. So in that case, it is ideal option to give a split pondic connector. That is, a pondic is split into mesial and distal half, and the mesial half is attached to the and the mesial half means it is attached to the respective retainers, and distal half is attached to this retainer. So this is how it works. So in this case, this is a split pondic connector, and mesial segment with a distal shoe, it is cemented first, and distal segment is the cemented next. So after cementation, it will engage us. This keyway should be fitting into the key. So this is how split pondic connector looks like. Next is the crosspin and wing. So it is also similar to that of the split pondic connectors, which is this is mainly used for in the case of a tilted abutment. If the abutment is tilted, it is difficult to get a parallel path of placement. So at that time, we can use the crosspin and wing connectors. Okay, in this case, the wing is attached to the distal retainer. So you can see this is the distal retainer, and so wing is attached to the distal retainer, which is cemented first, and the pondic is attached to the mesial retainer. So this is the mesial retainer. So after cementation, this is a crosspin and wing retainers, distal retainer and the wing, and the And the retainer pontic segment is seated finally. So final cementation. So first we have to cement the pontic with the wing. Then next is retainer with the wing, and on that this segment is then cemented. So the wing is attached to the distal retainer, which is cemented first, and pontic to the mesial retainer. This is to be cemented next. That is a cross pin and wing, and main use is for the management of the tilted abutment. So these are the three types of connectors. That is a tenon mortise, split pontic, and cross pin and wing. So coming to the special considerations, because we have already discussed that most of the rigid connection main indication is the pier abutment situation. So let's see what is pier abutment. Next we are going to see what are the special considerations while planning an FPD. One situation is the pier abutment, and definition is it is a natural teeth which is located between the terminal abutment that serves to support a fixed or removable prosthesis. So this is here the pier abutment is natural teeth. It is located between the terminal abutments that serves to support. So you can see on either side of the pier abutment, you can see the edentulous space. We can call it as an intermediate abutment. So either pier abutment, or we can call it as an intermediate abutment. So pier abutment is having edentulous space on either side. So mostly in this situation, we plan for a 5-unit FPD. But if we plan for a 5-unit FPD, all the natural teeth adjacent to the edentulous areas are to be planned as abutment. Forces are transmitted to the terminal retainers as a result of pier abutment will be acting as fulcrum that cause failure or loosening of the weaker retainer. So in this situation, if we plan for a normal FPD, normal rigid FPD, when the forces are transmitted, that will be transferred mesially, and that can cause the pier abutment will act as a fulcrum, and that can cause loosening of the retainer from the weaker retainer. That is here it is premolar is there, first molar is there. So abutment here from here it can easily weaken from the this anterior retainer. So sometimes the tension between the terminal retainers and their respective abutments rather than the pier fulcrum also causes intrusion of the weaker abutment, which leads to the failure of the weaker retainer. So that means there are two thoughts in this case. One is the when the forces, which is when the masticator load happens, forces are transmitted from this terminal abutment mesially, and it can cause the pier abutment as a fulcrum, and finally it can cause weakening of the weaker anterior retainer. So loosening of the weaker anterior retainer. The second thought is that it can also tension between the terminal retainers and their respective abutments rather than pier abutment acting as a fulcrum can cause intrusion of the weaker abutment. So here this anterior abutment is the weaker abutment. It can be intruded and leads to the failure of the weaker retainer, weaker anterior. So these loosened casting will cause the marginal leakage and the secondary caries. So we cannot give a rigid connections. So what are the reasons why we are not giving rigid connectors for a pier abutment is that one point is the physiological tooth movement. Second is the arch position of this abutment. And the third point is the difference in the retentive capacity of the retainer. That is disparity in the retentive capacity of the retainer can make a rigid connector, which is a less ideal treatment of choice in the case of a pier abutment. So use of the non-rigid connectors has been advocated to overcome this problem. So this is a stress breaking mechanism. That means we are breaking the stress which is transmitted to the retainers, and also which is transmitted to the pier abutments. So it consists of a T-shaped key which is attached to the pontic and a key wave which is placed within this retainer. So likewise, this is a non-rigid connectors. So location is very important. So it is usually placed onto the middle abutment, since the placement on the terminal abutment could result in pontic acting as a lever. So keyway should be placed within the distal contour of the pier abutment, and key should be placed on the mesial side of the distal pontic. So the key should be on the mesial side of the This is the key which is on the mesial side of the distal pontic, and keyway should be on the distal surface of the pire abutment. That is the in the retainer which is going to support the pire abutment. So that is position is very important. That is the distal contour of the pire abutment. That is keyway should be on the distal contour of the pire abutment, and key should be attached to the distal pontic. So that position is very important, and then only it will the proper action of stress breaking will happen. So that is a pire abutment situation. Next special consideration in FPD is a cantilever fixed partial dentures. That means what is a cantilever FPD? It is a FPD in which the pontic is cantilevered and is retained and supported on one end by one or more abutments. So only on one side the pontic is supported, and on other end it is cantilevered. That means other end there will be no support. This pontic is not supported from the other both sides. In a normal FPD, the pontic will be supported on both sides by the retainers, but in this case, supported by the abutment. But in this case, in the cantilever FPD, it is retained and supported only on one end by one or more abutments. So in this case, this is a cantilever pontic. So in a conventional FPD supported by abutments on either side of the dentures space, forces on the pontic are distributed evenly to both the abutments. So normally FPD means abutment pontic will be supported on either side by this abutment. In this case, the forces will be distributed evenly to both the abutments. But in the case of cantilever FPD, forces applied to the pontic can depress and tip the pontic. But this is a potentially destructive design with a lever arm created by the pontic. So it is of great importance that when you plan a cantilever FPD. So when you commonly give, if we give a cantilever FPD in all the situation, always the pontic in long term, pontic will depress and it will tip the pontic. So finally our processes will fail. So when you select an abutment or FPD, for FPD, there should be, we have to follow, it should follow, this abutment should follow certain requirements. That means the abutment should have a lengthy root with a favorable root configurations. That is a lengthy root with favorable configuration. It should have a long clinical crown, and the crown root ratio should be good. It should have a healthy periodontium, and it should be used to replace only one tooth. So these are the requirements that we have to follow while selecting as an abutment for a cantilever FPD. That is lengthy root, long clinical crowns, good crown root ratio, healthy periodontium, and should be used to replace only one tooth. So in what all cases we can go for a cantilever FPD? For example, if you are planning to replace a missing lateral incisor taking the support from canine, then the lateral incisor we can plan like there should be no occlusal contact on the lateral incisor, pontic, incentric, and eccentric relation. And also we have to plan a distal rust to be prepared on the central incisor that will support a mesial extension from the lateral pontic to prevent rotation. So indication is we can use canine for support. If you want to replace a maxillary lateral incisor, you can take canine as a support. And only thing is distal rust should be prepared on the central incisor to prevent this rotation. And second condition is that, for example, missing first premolar using, and we are taking using second premolar as well as first molar as abutment, and we can place the cantilever pontic as a first premolar. So if you are going to replace the first premolar, using second as well as first molar as abutment. So we don't have to touch the canine in this situation, because canine, if you touch the canine, you have to be extremely careful because it is coming next. You have to explain, you have to know what are things when you are replacing a canine. So here this situation also we can go for a cantilever FPD. Next situation is that missing first molars when there is no distal abutment. So you can use first as well as second premolar as abutment, and you are going to replace the first molar as a cantilever. As a cantilever pontic. That means you are as a cantilever FPD. That is first molar is cantilever. replacement using premolar as a pontic, as an abutment. So pontic should be similar in size to a premolar, but in this case, the pontic, we are not, even though you are replacing a first molar, it should be of similar size to that of a premolar. You cannot keep a pontic which is of molar size. So you have to should be similar in size to a premolar. Only light occlusal contact on pontic with no contact in the eccentric relations. So occlusal contact should be minimal, and pontic should possess maximum occluso-gingival height. There should be maximum occlusion. Otherwise, it can cause stress on the pontic and it can depress the FPD in that area. And fourth is that periodontally compromised teeth, as they have extremely long clinical crowns. In the case of periodontally compromised teeth also, you can go for a cantilever FPD, and in the case of a fire abutment situation, you can go for a cantilever FPD. Next type special consideration is the canine replacement FPD. That is, replacing canine with an FPD is difficult because the canine always lies outside the interabutment axis, and fulcrum line is labial to the arch circumference. Hence, the abutments are subjected to increased stress. So this is the reason why we have to be careful while replacing the canine, because canine is positioned outside this interabutment axis. So and also one thing is that when you replace the canines, the abutments are, one is the lateral incisor, which is the weakest tooth in the arch, and other is the first premolar, which is the weakest posterior tooth. That also makes our situation more complex. And forces acting on the maxillary canine usually act outward labially, subjecting it to a greater stress as compared to that of the mandibular canine, where the forces act lymphally. So always be careful while selecting abutments for this. When you replace, then canine is included in your FPD because of this reason, because it actually lies outside the interabutment axis. So thus we complete the special considerations in FPD. And as well as we have also talked about connectors in FPD, different types of connectors in FPD, the classification, and also special considerations in